All right. Well, good evening, good afternoon, everyone. Thanks for attending an exciting webinar Biomedics is hosting called Advancing Healthcare Equity by Addressing the Amputation Epidemic. My name is Chris Trigstad. I'm the Director of Marketing here at Biomedics, and I'm excited to introduce a couple of speakers. First speaker I have with me is Dr. Tracy Reed. She's a private practice podiatrist in St. Louis. She earned her DPM at the Dr. Scholl College of Podiatric Medicine. She's also a fellow at ACFOAM, and she's active in the sickle cell community. Dr. Reed, thanks for taking the time out today to be one of the speakers on tonight's webinar.
Thanks for having me.
Yeah, you're welcome. And the second co-speaker I have with me is Dr. Tracie Collins. She studied internal medicine and public health at Harvard. She was a former chair of the Disparities Task Force at the Society of Internal Medicine. She's currently serving as a Dean of Population Health at the University of New Mexico, and she actually starts a new job next week as the Secretary of the New Mexico Department of Health. So thanks for joining us, Dr. Collins.
Thank you for inviting me.
Yeah, you're welcome. Well, the first thing I wanted to touch on is definitely timely, especially with today's announcement and approval of the COVID vaccine, is thinking about disparities in care and, how racism is kind of shown in the healthcare community as well. Is one of the stories that has popped up is the fact that COVID is affecting communities of color at a higher rate. And Dr. Reed, I know that as a podiatrist in the St. Louis area, you've said that you're busier than ever, and it sounds like it is due to COVID. Are you seeing patients more frequently having COVID or more frequently impacting communities of color?
Definitely. I have had, I'm going to say at least 30% of my patient population has told me that they had COVID or that someone in their family has died from COVID. And at one point we were sending out get well cards and sympathy cards at a very, very high rate, especially like around March, April, and May. And there's just a lot of patients that continue to be diagnosed with it. A lot of people are continuing to be exposed from it. And it's pretty prevalent in my community where the numbers continue to go higher and higher and higher. And the hospitals have basically taken on the COVID population, and they've stopped all of our surgeries that aren't emergent at this time. So yeah, there's been a lot of different changes going on because of COVID, especially in my community.
Interesting. And Dr. Collins, I know, in addition to, COVID being, it seems to be more prevalent in communities of color, the statistics seem to indicate that outcomes are worse for Blacks and Latinos as well.
Yes, unfortunately, that's true. And it links to a prevalence of risk factors that put you at risk for complications from COVID. And so it's really devastating that these communities of color that are already dealing with challenges with chronic conditions and social determinants of health, that now with COVID, it's highlighted the inequities in their health outcomes.
Yeah, you definitely bring up a good point, and it's a good segue into the next section. The impact of social determinants on health. I think when we think about what makes a patient healthy, one of the commonly overlooked factors is where we live, where we work, where we play, the communities that we exist in, and the environment that we exist in. So, Dr. Reed, do you have any kind of stories about that and how you've seen how someone's maybe living situation has had an impact on outcomes in your patient populations?
Oh yeah, I have patients that they they wait until something is really, really bad, or they wait until they have gangrene because they can't come in because they have to work because they're basically living paycheck to paycheck. They have jobs where they have to be there. They can't necessarily work from home or anything like that, especially with the COVID going on. But they'll wait until the last second before they decide to come in to get something checked out that may have been waiting. They may have been waiting to see about it for 6 months, a year. Sometimes I've had people say, "Oh, this has been going on for 3 years," and you're like, "Oh wow." As a matter of fact, I just had a patient who he's made an appointment once a year, every year for the last 4 years, and just made it to my office this week, and he had some of the most severe critical limb ischemia I've seen in a while.
Oh,
And
wow.
yeah, it was really, really bad. I was like, yeah, you've got issues, sir. But it's because they don't make it in. They have to work, you know, trying to support the family and things like that. They'll put off foot care until they can't walk.
Yeah, yeah. No, I think you bring up a good point, and yeah, we definitely see and hear those stories every day. Well, Dr. Collins, I think one of the things that's traditionally being missed in the healthcare community is the reporting on these social determinants of health. I mean, CMS has found that of Medicare beneficiaries, only 1.4% had claims where an SDOH issue was actually being reported in the patient chart.
Right. And so we're beginning to do better, but I think we're kind of behind, obviously, in understanding the impact of the social determinants of health in these populations. You really have to begin to think about the fact that someone from even their young age has been in a community or situation where they've been in poverty. And so overcoming that and getting past sort of food deserts and unhealthy eating, having access to exercise, knowing the value of not smoking, these are things that are not happening until well into an advanced state of the disease. Like Dr. Reed just mentioned, someone showing up with really severe critical limb ischemia, had they had information and access to opportunities to have better choices, to have an environment in which they can exercise, to be able to eat healthier foods, and also to not be in a situation, and I know we're going to touch on this later, where there's constant stress from oppression, which leads to high blood pressure, which leads to cortisol surge, which leads to abdominal obesity, and then diabetes. These are things that are happening well before they ever show up in the healthcare system, and we're downstream trying to fix it.
Yeah, you definitely bring up a good point on that. Yeah, exactly. Well, I guess just we've talked a lot about critical limb ischemia, which is typically thought of as an advancement of peripheral artery disease. I think it's important to kind of review peripheral artery disease at a very high level. Here at Biomedics, we are definitely committed to the cause of early identification and therefore treatment. We're definitely big believers in utilizing lifestyle modifications as a low cost, low risk way to manage and treat PAD in a cost-effective way that helps reduce healthcare costs as well for the patient and for the healthcare system in general. Moving along, I mean, and we've talked about risk factors for PAD. Dr. Reed, in your patient populations, can you comment a little bit about the risk factors that you see, and do you see race having an impact on how often a patient would present with a risk factor when you're seeing them in your practice?
Well, in my practice, I would say probably 80% of my patient population is African American or people of color. And so most of them come in, and I would say quite a few of them come in with high cholesterol, high blood pressure, and diabetes. It's just like most of them have a lot of that going on. The smoking is definitely a high risk factor, and I see that a lot as well, but not as often as I see the high blood pressure, high cholesterol, and diabetes all put together.
Okay.
They just kind of seem to go hand in hand.
Well, so that's a great point. And Dr. Collins, I guess from a population health perspective, is there any research or any insight that that you have in terms of risk factors and how how race comes into play in terms of how often they present in a patient population?
Yeah, in the research that I've done looking at the prevalence of PAD, you can certainly see that older age is predominant among patients with peripheral artery disease. But when you begin to look by race, it's common that African Americans, Latinos, Native Americans are more likely to have diabetes, which is a big risk factor for PAD. And then certainly hypertension or high blood pressure among African Americans. So like Dr. Reed said, depending on the cohort you're working with, a lot of these risk factors come together. They don't just have one. They're probably smoking and have diabetes with high blood pressure and hyperlipidemia. So it's certainly prevalent among communities of color. But I do want to add that it's not race is not genetic, it's social. So again, looking at what puts someone in the position to develop diabetes in the first place, and are they using smoking to help offset the stress that they're experiencing by just trying to survive, which then does not help their blood pressure, which also their diet and exercise, and then the propensity for high cholesterol. So you have these communities of color with these risk factors, and they're more prevalent and more severe.
Yeah, you do bring up a good point. I think that the thought that maybe genetics did have a place in terms of the prevalence of some of these risk factors, I think has been kind of widely disproven. I definitely agree with you on that point.
Yes.
Well, so Dr. Reed kind of talked about, you've talked about a patient that took, a number of years, probably experiencing symptoms. And I think it's even more important to note that oftentimes we see patients in healthcare spaces that are either underreporting or not reporting their symptoms, or they're saying, it hurts when I walk, so I'm not going to walk anymore. But there's definitely, I think, an opportunity in these underserved communities to more widely screen for this disease, knowing that it is a progressive disease, so that that pain while you're walking turns into pain while you're at rest, can progress into ulcers, and then to Dr. Reed's point, critical CLI, and then gangrene and amputation. And this disease also, those clogged arteries in the legs and the feet also increases your chance for heart attack or stroke.
You've hit all the key points there, Chris.
Oh, thanks, Dr.
Yep.
Yeah, I mean, so obviously one of the big things about communities of color and amputation, with PAD presenting in these populations, oftentimes this leads to lower extremity amputation. Just been hearing a lot in the community about people that, especially minorities, are not presented with other treatment options outside of amputation when they're presenting with gangrene or CLI. So they're not being told that maybe an atherectomy, a balloon, or a stent or bypass could actually treat the disease. They progress immediately to an amputation. And Dr. Collins, I think you had done some research, was that in Oklahoma, about that subject, and specifically around, I think, the Native American population there?
Well, I've done a couple of sort of the health services research work. We're looking at the rates of amputation non-traumatic among African Americans and Latinos. And obviously in African Americans and Latinos, it's like 1.4 and 1.3 times more likely than non-Hispanic whites to undergo non-traumatic lower extremity amputations versus bypass surgery. And you have to think about the size of the vessels that are impacted by plaque buildup and occlusion and stenosis, which largely, particularly in African Americans, it's more the smaller vessels, whereas in non-Hispanic whites, it's larger vessels, which may make them more amenable to intervention, but we've got a lot better and doing good jobs with lower extremity circulation and even smaller vessels. So I think at this point, it's about educating the public and making sure people understand that just because you're older and you're, walking and you think you're slowing down and you're having discomfort, that isn't normal. You really need to get in and seek care as soon as possible so that people can begin, physicians, clinicians can begin to act and help you to prevent progression. And it's also multidisciplinary. So if Dr. Reed is seeing someone several years after they've been trying to get in to see her, she's going to work with the wound care specialist. She's going to work with, interventionalists who are going to go in and open up those arteries. And so it's, we need to have teams together, and we need people to get in sooner rather than later.
Yeah, you bring up a good point. Dr. Reed did share with us a story a couple of years ago about I think it was a female who couldn't even go to the store by her house anymore without experiencing pain, and you were able to do a PADNet test on that patient. And I'll let you continue the story.
Okay. Okay.
Yeah.
So I did a PADNet test on her, and basically she flunked. I ended up sending her to vascular, and they did revascularization on both of her legs. She was a very, very heavy smoker. And she was so excited that she could walk better. She was like, it was a new life just because, she got the help that she needed. She didn't even know there was anything that could be done about it, because she had originally come to me for an ingrown toenail. And I started asking questions. I could tell she didn't really have good pulses. So the more I talked, I was like, we need to get you checked, And I really think that it's a lot about educating my patients, because a lot of them have no idea that there's anything that can be done about different lower extremity problems. And a lot of them don't come until they've got an ulcer, or they know somebody that did have an ulcer, and they're like, oh, well, let me go to a foot doctor just to double check and make sure I don't have one too. That's how a lot of my patients end up coming in. But sometimes I've noticed that a lot of my patients, not necessarily my patients at first, but they'll go to the emergency room with a problem and end up getting an amputation, where I'm like, they didn't even try to fix them. It was like a wrap. It's like you show up in the ER and it's over.
Yeah, that is really depressing. I mean, we know about the the outcomes, and it's kind of a downhill spiral when someone typically experiences an amputation. And I think it has a significantly negative impact on their life. And I think if you think about someone who is living maybe a sedentary lifestyle and they're not exercising enough, making them experience an amputation is probably not going to increase the chances that they're going to walk more often.
And can I add one thing to that? Because I actually had a veteran patient tell me that he'd rather just have the amputation than deal with the pain. I think that came from a place of, I'm not aware of any other options, so do something quickly and do it now. So I think, again, education and helping people understand their options is important.
Well, that's interesting. I've never heard, that's an interesting story.
Yeah. And Chris, I just want to say that there are questions in the chat box. Should we begin to answer those, or just?
Yeah, no, that's a good point. Let's see. Yeah, I'll ask this question, and then before I ask this, just want to let everyone else in the webinar know there is a Q&A button that you can hit, and if you have a question that you'd like to get answered, we can ask this right away. Dr. Collins needs to step away at about what is that? About 15 minutes before the hour.
10 till, yeah.
Yeah, so I think it makes sense. We'll answer these questions, I think, during the webinar. So first question comes from someone that's asking, in your experience, who tend to be the most trustworthy messengers of healthcare information in African-American communities, and if different, in Latino communities?
So if I could start with that, in the work I've done, when you talk to patients, at least when I've talked to veterans, about how they want information conveyed and who they want to deliver it, certainly having someone of the same race is important, but even more so having someone who's compassionate and with whom you have a trustworthy relationship. So if they trust you, it's more likely they'll listen to you. And that's for African Americans and Latinos. However, if you talk to non-Hispanic whites, it's not so much about having that special relationship. It's more about a business. Like, can you convince me from a business perspective that this is the best approach for me? That's been my experience.
Yeah, that does sound true to me too, for sure. Yeah, and I think we've heard stories about there being a general distrust within African American communities to the healthcare providers. So I think you're probably right. Having someone deliver that sort of message that is the same race definitely can carry more weight. What do you think, Dr. Reed?
I think it definitely carries more weight when people of color have doctors that look like them. But I agree with Dr. Collins as well, because you have to have some type of trust between you and the patient. And so even though you may not necessarily look like your patient, if you take the time to listen to them and they learn to trust you, then they will, take your information and use it wisely, so to speak. But I definitely hear a lot of patients that are like, I didn't know you were here. I was looking for a doctor. I was looking for a Black female doctor. I was looking for a Black doctor in my city. And so a lot of patients find out about me, I guess, through word of mouth and things like that. And they kind of want to stick to someone that they feel like is more like them. But sometimes I still feel like they don't trust me anyway.
Oh, interesting.
But there's just a general distrust of the healthcare community from African Americans, just because of the history of things like the Tuskegee experiment and things like that, where a lot of patients don't even think that they would want to be in any kind of trials or anything that sounds like it's an experiment. They don't want to be bothered with.
Yeah.
Yeah.
I think that makes sense. Yeah. Well, I'm sharing here some U.S. amputation statistics. I think it's important to just see how widespread this problem is, how much it costs the healthcare system, and most importantly, the cost of an amputation. We hear from some people that think atherectomy or other interventional procedures are expensive, pricey procedures. But compared to an amputation, if you think about an atherectomy procedure, if that is typically $15,000, well, an amputation, although it may seem to be cheaper up front, when you factor in all the other associated complications, the 2-year cost of that amputation quickly grows to be well over what an atherectomy would cost. So just thinking not only from the perspective of the patient's quality of life, but also saving the healthcare system, I think early identification and exploring all sorts of different options, I think are definitely important to improving outcomes and then helping to bend the cost curve. So there's a good body of research about the fact that PAD-related disparities definitely pop up. Dr. Collins, I think you talked about the fact that African Americans are much more likely to lose a limb as a result of PAD. But also another, I think, important point is research indicates that African Americans tend to develop chronic conditions up to 10 years earlier. Is that something you've kind of seen in your research as well?
Absolutely. And when you think about Native Americans, there's this association between chronic kidney disease, which is also in African Americans, that's associated with PAD and having more severe disease. So you have this compounding of the risk factors. So you have the hypertension, the diabetes, chronic kidney disease, dialysis, and then PAD, severe PAD, and amputations. So it really is pretty common in African Americans, Native Americans, and Latinos.
And Dr. Reed, any thoughts on this too?
Oh, yeah, there's a lot of a lot of factors that go into the health disparities just because patients can't, sometimes they say they can't afford medication. They don't necessarily get their, they don't necessarily do all the things that we ask them to do because either they don't have time to do them, they don't have the money to do them, or they may not necessarily be able to make it to the other doctor that you sent them to because they have no transportation, and different, factors that come into that we don't necessarily think about until you're in that situation or you have a patient that's in that situation.
That's a great point, and it actually I think kind of leads into another question from the attendees. I'm just going to read this off, and I'd love to get both of your thoughts on it. The question is: should most to all amputations be preventable if the patient is appropriately treated, or do some PAD cases result in amputations regardless of primary care interventions?
So I'm going to jump in there. If you can intervene at a time when the disease is not so severe and it's amenable to intervention, you can prevent the amputation. But as Dr. Reed pointed out earlier, sometimes patients come in with such severe disease that there really are not a lot of other options. I will say I have seen improvement in what we're doing with endovascular intervention with critical limb ischemia. So we're getting better, but I can't say that we can prevent all of them. It really depends on when they show up for care.
Yeah, I think I agree with you. And what do you think, Dr. Reed?
Yeah, I think that it definitely depends on when they show up. The earlier they show up, definitely the more preventable it is. Sometimes just basic foot care can prevent some of the amputations that people have, but sometimes people don't do basic common foot care. And so, some of the things that I'm seeing is just basic. Keep your feet clean, keep them dry, put on socks, stop wearing shoes that are 40 years old that are rubbing and causing ulcers in the first place. Some of those things that is just basic good hygiene and good foot care can prevent a lot.
I definitely agree with you on that. So, yeah. Well, thanks for responding to that question. So we've talked about a little bit, I think, throughout this this webinar about some of the factors that are leading to driving these poor outcomes. I think we talked a little bit about large arteries versus small arteries, a little bit about genetics. I think there's some recent research that indicates, African ancestry is not an innate heart disease risk factor. Also, when they started looking at, well, why are communities of color experiencing worse COVID-related outcomes? The research indicates that it's the lack of healthcare access. And building on our first question from the audience, it's pretty clear that African Americans are underrepresented in the healthcare community, and I think it's really important. What can we do to help improve that, and to get more people from communities of color involved in the healthcare space, so that they can be the messenger about this disease. And Dr. Collins, I don't know if you have any thoughts on this.
Yeah, when you think about, at least to the question of more representation among communities of color, you have to think about the pipeline and being strategic and intentional about making sure that you're pulling in students from communities of color, African American, indigenous communities, Latino, and preparing them to be ready to go into med school and then to complete. And so the retention piece is also important, and the residency, and making sure we have a system set up to welcome them and treat them like they belong when they're there. That pipeline process and that retention process can help us increase the prevalence of physicians who represent communities of color. And I think it's important. Like I mentioned earlier, the trust is important, but also having people with whom you identify is very important to patients. And when you think about COVID and you think about communities of color, Well, think about our public health messaging. You know, distance. If you're in a multi-generational household, it's hard to distance. And if you're in a place where there's not running water, hard to wash your hands. So we have to, again, I hate to beat a dead horse here, but go back to those determinants of health. Do we have the mask? Do the folks who are the people in communities of color who are most likely to suffer, they're also the ones who are frontline workers and don't have the option to work from home, and they're more likely to be exposed. Therefore, they're more likely to have COVID, and then because of chronic conditions, to have severity. So we've got a system set up in this country, systemic racism, that we really need to begin to address and stop putting a Band-Aid on it.
Yeah, I definitely agree with you. And yeah, specifically around social determinants of health, I think that is definitely underrepresented in the community, and definitely agree with you on that point. Let's see. I think, this webinar is just one of the many things that we're trying to do to address some of these inequities in healthcare. But I think the AMA, the American Medical Association, has now started addressing this. The American Heart Association has also started addressing this, identifying structural racism and racism as a public health threat, and having a negative impact on the healthcare system in general. And Dr. Collins, I pulled a quote out of the publication you were recently published in. I thought it was really interesting.
Yeah, I appreciate that. You know, it kind of builds on what I was just saying, that we really have to begin to take a step back and look at the bigger picture of what are we doing in this country to provide access to neighborhoods with sidewalks, to give each person an opportunity to buy a home and have ownership, have assets, to then be able to allow their children to go to schools and get a good education, to make them competitive for these jobs that then down the future, in the future, they then can have their children set up to do well. And we're not allowing the perpetuation of oppression to continue, which then helps us really begin to address this pandemic of racism.
Yeah, I definitely agree with you on that. And I just had a question pop up. This, I think, would be great for Tracy, Dr. Reed, and Dr. Collins. You may want to chime in on this as well. I'm going to read the question right now. This webinar suggests that primary care physicians and podiatrists should be actively involved in assessing whether a patient has PAD. Do we need to worry that vascular specialists will be upset that we are encroaching on their diagnostic business? Or do you think specialists want us to be engaged on this front?
Oh, I don't think that the vascular specialists should be upset that we're, on the diagnostic part of this chain, because we're finding things that they may not ever see until we send them to them. So we should all be working hand in hand. I don't think that they should have anything to worry about. I think that actually they should be happy that we are, doing a lot of this and making recommendations to send them for further testing and examination and treatment for the issues that the patients are having.
So yeah, you as an active PadNet user, I mean, it sounds like you're actively referring patients to kind of that nearby vascular specialist. It's been a positive experience in your so far?
Yeah, definitely. There's two that I refer to a lot, and it kind of just depends on what type of symptoms the patient is having, which one can get them in quick enough. But it's great that I have two vascular specialists that I refer patients to a lot. One of the problems with just healthcare in general is that sometimes the primary care doctor has to do that referral. Most of the time, we haven't had any issues with the primary care doctor doing the referral because the patient has an HMO and they have to have a referral from the primary. But every now and then there'll be a primary that's like, no, I want to send them elsewhere, here or there. And as long as they get sent somewhere to get the problem addressed, I'm really good with that. But I don't think that most of them that I know have a problem with me doing any of the diagnostic testing.
Oh, okay. Okay. Well, that's great to know. Great feedback. So, Dr. Collins, one of the things that we have recently been working on is a way to aggregate multiple chronic conditions, including PAD, as well as other chronic conditions like peripheral neuropathy, and then be able to report on social determinants of health, identify COPD, and analyze social determinants of health. In your experience as a kind of a pop health expert, have you do you see value in a platform like this?
You know, absolutely. I see the value in bringing things together, centralized and comprehensive. So I think this is excellent. I think it's very useful. And it makes me think about COVID right now and how we're going to figure out kind of once we get past the healthcare workers and long-term care facilities and the essential workers, who those high-risk patients are and identifying them and having a platform to go to and quickly create a list of who needs to be reached first is very helpful.
Yeah, I definitely agree. And from our experience that we've seen, it's really interesting. These multiple chronic conditions. I think we've talked about the fact that they kind of multiply the chance that someone's going to have an adverse outcome. But also, behavioral health is health, right? I mean, there's evidence that suggests that first of all, an amputation leads to a high rate of depression, which makes logical sense to me. But also on the flip side, if someone has depression, they're more likely to have worse outcomes as a result of that as well. And yeah, can you kind of, do you have any thoughts on mental health and how that impacts some of the healthcare choices a patient could make?
Oh, absolutely. When you're in a state of depression, major depression, or other mental health disorders, you're not able to really process all that you need to do for other issues. So then it compounds, it escalates the poor outcomes that you can have from not taking your blood pressure meds and not taking your meds for the depression. And then the behavior that you have, you're really at risk. So I think that understanding behavioral issues is really key. And we have to be careful because a lot of times in certain communities, you're not really encouraged to come forth if you're concerned about your mental health. But I think we're working now to get, move past that stigma and get people to recognize that having an antidepressant is as important as having your medication to control your glucose. You can't ignore that.
Yeah, I definitely agree. Yeah. And we got a follow-up question as we were talking about screening for PAD, to kind of take a step back. Dr. Reed and Dr. Collins, when we think about who to screen for PAD, in your estimation, is a criteria, in your opinion, different for Latinos versus African Americans versus non-Hispanic whites?
My perspective on that is I feel like the data that's out there on who should be screened is really biased towards non-Hispanic whites. If you look at the AHA, which I think it's a great association, but when they give you guidelines about who to screen, it's really focused on non-Hispanic white population. So it's hard to generalize those findings to communities of color. Now, given my clinical experience and my research, I would say that what the AHA is recommending, ACC, it's like 65 and older or having a risk factor or symptoms, it may not be adequate for communities of color, that we may have to start a bit sooner. But I've not seen the data to confirm that, but that's my suspicion.
That's an interesting point. Dr. Reed, what do you think? I mean, maybe just to key on one point, we've talked about the AHA screening recommendations being adults 65 plus, and Dr. Collins is maybe recommending that an earlier age may be a better way to go. Do you see PAD popping up earlier than 65 in some of the communities of color you're serving?
Oh yeah, I see PAD popping up in people in their 40s, sometimes even late 30s, depending on certain risk factors. But yeah, I pretty much screen across the board all my patients anyway, just because that's just one of the things that I like to check and make sure that my patients are getting good care, or at least as good as I can do for them. But yeah, that 65 and over definitely needs to come down. At least it would definitely come down for my patient population if they actually tracked it.
Interesting. So when you think about someone coming into your practice, do you follow different protocol based on the patient's background?
No.
Nope. Okay. Okay. Well, that's great to know.
No.
Yeah, and so we're getting kind of close to the end of the this webinar, and I know Dr. Collins, you have some other things going on. Want to talk a little bit about coordinated care, and you know, I think at Biomedics here definitely committed to figuring out how we can leverage technology to deliver community-based coordinated care. Definitely the research indicates that this can lead to better outcomes. But do you have any experiences with kind of whether it was in Oklahoma or New Mexico or Minnesota, some work where you've seen coordinated care having an impact on a community?
I have, and in Minnesota, I saw great effort and good outcomes with multidisciplinary approaches and coordination of care, particularly with patient-centered medical homes, and having kind of one area or one place where a patient can come, but access the various disciplines that can help manage their disease. You certainly see fewer hospitalizations and fewer adverse events when you have that coordination of care.
Well, that's great to know. And Dr. Reed, sounds like you have quite a bit of experience with working in in communities to collaborate with these specialists to deliver better care and better outcomes.
Oh yeah, it definitely has to be a team effort for some of my patients, because you have to talk to the primary about certain things. You have to talk to the vascular doctor about certain things. You have to talk to their endocrinologist about certain things, and try to keep everybody in the loop just to make sure that this patient stays as healthy as possible. So it definitely takes a team effort.
That's great to know. Thanks for that, Dr. Reed. Yeah, so kind of done with the slides, and now would be a great time to ask questions if any attendees have any questions. And I'd like to just ask Dr. Reed and Dr. Collins, we have a number of attendees. We are going to make this webinar available on demand. But for those in the healthcare community, what are some other things that we could potentially do to help improve outcomes and help kind of address this racism epidemic? How do we, what are some other things that we could potentially do to reduce amputation rates, specifically in these communities of color?
I think that we really need to go back to that coordination of care, and primary care doctors have been really well versed on understanding racism. We still have work to do, but on understanding determinants of health. I think that needs to extend to the specialists. I happen to reside in two camps. I mean, internal medicine is my training, but I'm on the medicine side as a vascular specialist. And I know at vascular meetings, there is very little uptake of understanding racism or even accepting it and recognizing its role and poor outcomes. So I think we need to begin to come together to have these conversations, because right now it's like the primary care docs, and then like Dr. Reed and doctors with her specialty, she's an exceptional example, but there are plenty who may not quite get the importance of understanding the determinants of health and what their role is. And I think that's where the partnership comes in with primary care and the specialists.
I think that's a great point. And Dr. Reed, what do you think? Anything else? If a healthcare professional is attending this webinar, are there any other things that you would suggest as well, or?
I would say that if they could just try to talk with their patients and give them the overview about good foot care and preventing the amputations, and maybe make sure that they're getting their foot exam, because sometimes patients don't even take their shoes off with the primaries anymore. Sometimes they do, sometimes they don't. And so they may not necessarily see anything, but just remembering that all of it, you know, the whole body needs to be taken care of would probably help as well. Another thing that I think may help the entire community is maybe something like those public service announcements, or just like those commercials that they have for different medications and things. Patients sometimes like to see themselves in those commercials, or they'll be like, oh, well, that's not for me because I don't see anybody there that looks like me. But you know, having a more multicultural type of message that gets out to the public would definitely, I think that would help a lot, because patients like to talk about what they see on TV, but they're only talking about certain things. But they do talk about those medication ads a lot, and they talk about those infomercials that they see. And I think if we could get a message to them to, you know, make sure they're taking care of themselves and taking care of their bodies, and reducing the amount of amputations, I think that would really catch an eye, and maybe get some more people to go to the doctor like they should.
Yeah, you definitely bring up a great point on that. I think we at Biomedics, you know, we are headquartered out of Minnesota. So when the George Floyd incident happened, we definitely kind of took it to heart. We had a in-service really to kind of focus on this this issue. And, you know, I took the time to visit the George Floyd Memorial, and, you know, we've been trying to figure out, you know, how do we make our marketing material more diverse? You know, for example, some of the patient education materials. I know I sent you a poster. This is probably a couple of years ago, and you wanted that poster, you wanted the patients to look like your patient population. So I definitely remember that experience. So we've, as a company, been trying to figure out how we can do more. And yeah, part of that is for patient population, or I'm sorry, patient education. How do we make sure that our materials are more reflective of these different communities that are out there?
Yeah, and I want to thank you again for fixing the poster for my patient population. They look at it all the time, and they always are like, oh, look at that. Let me ask the doctor about my legs real fast.
Oh, that's great to know that it's having an impact. That's awesome.
It is. It is.
Can I just put a plug in? I love what you guys are saying. And it just made me think, you know, given COVID, we're in the telehealth sort of mode, but you can check someone's feed on a video. I mean, you don't have to have them there in the office with good, you know, lighting. And so I agree with Dr. Reed. I love the point about just having them take off their shoes, because sometimes there is the cutting of corners and saying, oh, don't worry about it. But then you're missing an opportunity to really help your patient.
Yeah, that's definitely a good point. It's not that hard to point a smartphone a few feet down and get them to take their socks off. Yeah, even in a telehealth encounter. That's absolutely correct.
Yeah, I've done quite a few telehealth since COVID started, and I have people putting the phone up to certain parts of the foot, and so I can see what's going on.
Oh, okay. So the camera's good enough to help, you know, inform you of what's going on with that patient. That's great to know.
Yeah.
Okay. Well, it looks like we don't have any other questions from attendees. And Dr. Collins, Dr. Reed, I do definitely appreciate your time. And if there's anything else you want to add in, let me know. But I did want to take the time to thank you. I know that you're both very busy in your practices, Dr. Collins in your new position as well. So thanks again for taking the time out to talk about this, I think, important topic.
Well, thank you. I've enjoyed this. And thank you, Dr. Reed.
Thank you. It was great.
You're welcome. Well, thanks again, everyone. Have a great night. And again, I appreciate the time.
Okay, thank you.
Thank you.
Bye-bye.
Bye.
Bye.